disorders. Some folks, and it is FDA approved, for up to 10 to 12 milligrams a day. Think about that one. That's high dose alprazolam. That person has to be pretty darn ill. So again, keeping in mind your dosage, that is the only exception that you have to the dosing of benzodiazepines for the anxiety disorders. That for panic disorders, clinicians can crank this one way up. Okay, and there doesn't seem to be a dose ceiling. So that's where you get the issues of tolerance and withdrawal become a real big issue with alprazolam. We'll get to that, okay? I know that Dr. Emmett mentioned about the anxiolytic agents through the GABA system and the GABA receptor. So keeping in that mind, and also keeping in mind that also causes sedation, some of the other clinical symptoms that we see with benzodiazepines. So this is what you see with the kinetics. Again, as I mentioned earlier, you see what we have here. I'd like to take a couple of take-home messages on this one. The long-acting ones have what in common? Active metabolites. I think Dr. Emmett mentioned about them, right? About active metabolites with these long-acting ones. These active metabolites are equal potent as they are to parent drug. So you can see that that's the reason why their half-life is so long. Like for diazepam, up to 80 hours. So you can imagine a person just taking chronic diazepam, how much that builds up in their body, and then think about it that if an elderly person uses it, then you have a real big problem with that. So that's the take-home message on the kinetic slide with these long-acting agents that, yes, they do certainly have active metabolites, and they're equally as the parent drug. The interesting thing, and I'll mention it with clonazepam, is the only difference in metabolism here is nitroreduction. And again, it lasts a long time in the body as well. And so that's the only thing different about metabolism with these particular ones. And then lorazepam and the oxazepam are directly conjugation, or what we call phase 2 metabolism. Okay? And then the protein binding is listed all for you. All you have to keep in mind is they're all highly protein bound. So that's how they differ. Their dynamics are all the same. Benzo is a benzo is a benzo. Sedation, muscle relaxation, right? Anticonvulsant, right? And what else? What's the fourth one? Anxiolytic effect. Anti-anxiety, it's what they were designed for. Okay? So keep in mind those four things. So if you have a person who's dependent on the drugs, guess what happens when you discontinue them too fast? You could get withdrawal. And it's exactly the opposite of those four things. You could have seizures, you could have muscle aches, you could have insomnia, and you get rebound anxiety. Okay? So, take-home message there. A little bit more about kinetics and dynamics. They're highly lipophilic. They enter the brain easily, and then, of course, exit the brain easily. Okay? A little bit about kinetics yet. With diazepam and chlorazepoxide. These are really old agents. The story with this is that they shouldn't be given intramuscularly. It's kind of like the same story with intramuscular phenytoin. You have erratic absorption. It's better to give these intravenously, slowly, okay, if people decide to use that. You'll still see IV diazepam emergency departments for seizures. You won't see it for anxiety. Okay? So keep that in mind, but hopefully you don't see any more orders for IM administration of these two agents. The reason why it's painful is a similar story with the phenytoin. It's the diluent propylene glycol. You get crystals. Not a good thing. And that's why it becomes painful. Okay, metabolic process, P450, I put an example for you, 3A4 and glucuronidation. So just now think about this. What liver enzymes are inhibited by SSRI antidepressants? P450 what? 3A4, 2C9, 2C19, potentially 1A2, depends which one you put about, 2D6. So just think if you combined an SSRI antidepressant with a benzodiazepine, and if you're looking at it from a diazepam viewpoint, it's got a half-life of 80 hours, and you added an SSRI to that, you just caused what? A pretty significant drug-drug interaction. The half-life of diazepam may have just doubled. Wow. And the person is really sedated. So those things you think about, okay, with drug-drug interactions. So that's why knowing the specific metabolic process is important. Again, that's why lorazepam and oxazepam are preferred, because they don't undergo those CYP metabolisms. They go directly to glucuronidation. And that's what I mentioned. And here we are. And you can see some of the other specifics that we have here. Okay? Now, the one thing on the last bullet, clorazepate is a prodrug. It is converted, and it is inactive. So it is converted to desmethyldiazepam, the active metabolite. And it has to be under acidic pH. So if a person takes antacids and then takes their dose of clorazepate, it's not going to convert by acid stomach, and the person will not get any benefit. So you have to separate it by at least an hour to 2 hours if the person has any antacids. So that is the one caveat from clorazepate. Efficacy. To mention, these drugs work. Works within 2 weeks. Rapid. Works within the first day in some patients, okay? However, keeping in mind, it's only effective for the somatic symptoms, and it sedates people, so that's why they worry less. Doesn't really hit the core worrywart. I love that one, the worrywart, okay? Like that one? So that core worry thing, well, you'll sedate them, they'll feel a little bit better, but their muscles will feel really good, okay? They've shown with long-term studies that at least half folks fail to reach remission, meaning that it never goes away, yet they're now what? They're hooked on the benzodiazepine. So that's really not good. And then if you take them off it, even if you do a slow taper, and we'll talk about that, that relapse rates will actually exceed antidepressants. So you could see that from an efficacy viewpoint, they're only good for what? Short-term use, right? Short-term, boom, acute use, maybe a couple months, okay, till the antidepressants kick in, and then taper them off. And of course, they have these particular adverse events. So we talked about it: sedation, drowsiness, ataxia, psychomotor impairment. Yes, but you do get tolerant to that. Just think of the person who's on 10 milligrams of alprazolam. You wonder how they drive their car. Whoa, yeah. All right. The other thing is also, that's where tolerance comes in. That's how they drive their car. But just think about how much they had to get to there. And then, of course, we know benzodiazepines do cause memory impairment and recall. And it's called limited to events after drug exposure. So what we call anterograde amnesia. Okay? So, kind of an insomnia thing here. So let's say you're nervous, you can't fall asleep, and you're studying for a test, but you need something to help get you to sleep, and you take a benzo. Don't do that. That's what's going to happen. You're not going to remember anything. Okay? That's how you use this information. If you study first, you're tired, you need to go to sleep, and you take a benzo, guess what's going to happen?
So you don't remember anything before, but you remember things after.
Yeah. Oh, okay. Was that a bit of practical information? Okay. Huh? Very useful. There you go. Right. So again, keeping in mind also when folks use this long term, they may get the anxiolytic benefit, but they still could get memory impairment. Hard for them to learn things. Okay. Now, I know you're familiar with abuse, tolerance, and dependence and withdrawal. That is very famous that occurs with this class of agents. Obviously, you've got to be careful when persons who abuse other drugs can be prone to also abuse benzodiazepines. You know what dependence is. So that's why you need to do withdrawal very slowly. When they say slowly, there are no rules or guidelines. I know we teach you lots of guidelines, but there are no guidelines for this one. It'll be up to the individual physician. Some may do it very slowly based upon their experience. 10% per week. Okay. Some will go 25% per week. Okay, that's fine. There are no rules for that. Okay? Yeah. Yep. The question is that she's heard of TAPER protocols. That's fine. It's developed in-house by that organization. They will also use TAPER protocols if they use benzodiazepines for alcohol withdrawal to detox them. Good question. But they won't have they rarely have protocols for tapering for generalized anxiety disorders. Okay, good question. Okay? Now, there's a caveat to the withdrawal that's not on the slide, but you want to take a note. This is when I talked to a lot of physicians who worked with alprazolam and it came out. When you get down to that last 1 milligram and you try to get them off alprazolam, that last 1 little milligram of alprazolam is really hard to get them off. They've been on this drug for a long time. So they may have to go like alprazolam 1 milligram. It could be like 1/4 milligram QID or 1/2 milligram BID. They may have to keep them on that for like several months. We don't know what happens, but people really have that problem getting them off that last milligram. And then they have to go down to maybe alprazolam 0.25 BID. Keep them there on for a couple of months. So it's really interesting that last milligram of alprazolam is really hard to get patients off of. And a lot of clinicians and psychiatrists tell me that all the time. Okay? Not in your textbook, but it's out in the real world. Now, if you suddenly discontinue them, that is really not a good thing because you can get rebound anxiety, meaning that the symptoms are actually greater. So that is not good. And certainly relapse can occur. Symptoms, again, as we mentioned. And then even at seizures. So be careful with that. Now the caveat with withdrawal, if it's a short acting, it occurs sooner. If it's long acting, it could be drawn out. So this is where kinetics and dynamics play a very good role in the withdrawal of these agents. So yeah, the long-acting ones, they last longer in your body, but if you stop them, that could have withdrawal maybe a week later. Many physicians forget that. So we can't, okay? And of course, you got your drug-drug interactions with alcohol. I use the example of Heath Ledger. Remember Heath Ledger? Anyone, the actor? You think about how much anxiety, how he could not fall asleep in his last role as The Dark Knight. Anybody watch that movie? Didn't he scare the bejeebas out of you? That kind of thing? Well, yeah. But just think of him trying to fall asleep. So, that's what happened to him. Alcohol, benzodiazepines, and then he actually took took 2 classes of benzodiazepines. He took alprazolam and triazolam and an antidepressant, and then drank alcohol. Those are things that are unfortunate. And of course, you got to watch out for all those drug-drug interactions similar to that. The general rule for benzodiazepines is go slow and go start low like any other agent. So you just titrate. Last bullet's important. Can be used on PRN basis. So for example, you have a person on generalized anxiety disorders. They're on SSRI antidepressants, and then they have a breakthrough episode, acute anxiety, for whatever reason. You can use them for 1 to 2 days or 3 or 4 days, that kind of stuff, and then taper them off real quick. That's okay. So can be used on PRN basis. Antidepressants cannot be used on PRN basis. Okay? First question. Thank you. All right. Which of the following statements best describe benzodiazepines? Onset of withdrawal is linked to their PK. Elimination rate is a key factor in CNS uptake. Physical